Anesthesia for renal surgery. Key points: renal surgery is major and painful with risk of complications like hemorrhage. Patients often have pre-existing or may develop renal impairment post-operatively. Introduction: kidneys filter plasma, maintain homeostasis, secrete renin and erythropoietin, help convert vitamin D and excrete metabolized drugs. Receive sympathetic and parasympathetic vagus innervation. Kidney pain referred to lower back, flank, scrotum, labia due to nociceptive fibers traveling with sympathetics. Surgery: common procedures: pyeloplasty, nephrectomy, nephrolithotomy. Many are now minimally invasive, e.g., laparoscopy, ureteroscopy, lithotripsy. Surgical positioning: lateral with raised loin, improves access but has implications. Preoperative assessment: evaluate renal function, control hypertension, and manage comorbidities. Urinalysis, FBC, creatinine clearance, serum electrolytes, ABGs, ECG, chest X-ray may be needed. Avoid routine transfusion unless necessary. Optimize fluid electrolyte status and treat infections. Plan perioperative management for diabetics. Consider antacid prophylaxis in renal failure, drugs and renal function redistribution and metabolism, and most anesthetic drug action, not renal excretion. Adjust doses of renally excreted drugs, e.g., vecuronium, neostigmine, atracurium and cisatracurium preferred for renal failure, non-renal metabolism. Morphine and pethidine have renally excreted active metabolites. Use cautiously. Avoid NSAIDs in renal impairment. Paracetamol is safe. Inhalation agents like desflurane are safe. Sevoflurane and fluorane can raise fluoride levels but generally safe. Anesthesia. Intraoperative general anesthesia with IPPV and muscle relaxants is standard. Use large bore IV access. Preserve forearm veins for future dialysis. Endotracheal intubation recommended for laparoscopic cases. Atracurium is the muscle relaxant of choice in renal impairment. Positioning: full lateral position affects ventilation perfusion, may decrease cardiac output. Use supports, padding, and secure strapping to prevent nerve injuries and movement. Avoid compressing vascular access, e.g., AV fistulas. Positioning details for understanding. Full lateral position improves surgical exposure, especially for open nephrectomy. Affected side up, loin elevated with padding, kidney bridge. Respiratory effects: ventilation reduced independent lung due to gravity and compression. Perfusion increased independent lung, creates VQ mismatch. FRC, thoracic compliance, tidal volume, and vital capacity decrease. Use FiO2 and low PEEP to prevent hypoxia. Cardiovascular effects: table break, kidney bridge may compress IVC, especially on right side. Venous return and company, mediastinal shift. Hepatic pressure also reduce preload. Monitor BP and CVP carefully during and after positioning. Nerve injury risks: brachial plexus, arm stretch, cervical plexus, neck twist, common peroneal nerve, fibular head compression. Use arm boards, padding, neutral neck and shoulder alignment. Pillow between knees, flexed lower leg, protect pressure points. Wrap and protect AV fistula sites. Monitoring: close cardiovascular and respiratory monitoring is essential. Consider invasive BP and CVP monitoring, especially in ESRD or major tumor resections. Use ultrasound guidance for central lines if access is difficult. Fluid balance: pre-op dehydration common, due to bowel prep or dialysis. High fluid requirements intraoperatively due to losses and bleeding. Avoid potassium-containing fluids in renal impairment. Monitor urine output. Tailor fluid therapy, especially in anuric or recently dialyzed patients. Vasopressors and antihypertensives treat underlying causes of hypertension first. Phenylephrine may reduce renal perfusion. Dopamine is an alternative. Avoid sodium nitroprusside in renal failure. Use nitroglycerin or hydralazine cautiously. Labetalol and esmolol are safe and commonly used. Renal protection: avoid hypertension, dehydration, sepsis, and nephrotoxic drugs. No proven benefit from diuretics, ACE inhibitors, or dopamine for renal protection per Cochrane review. Complications of surgery: bleeding is a major risk due to kidney vascularity. Use acute normovolemic hemodilution or cell salvage or fibrinolytics. RCC may extend into IVC. Right atrium may require bypass. Risk of diaphragm, pleural pneumothorax, or bowel injury. Laparoscopic surgery can cause hypercarbia, acidosis, and subcutaneous emphysema. Postoperative pain relief. Epidural analgesia is best for open surgeries. Avoid coagulopathy. T8 level OS required for analgesia. Alternatives: subcostal catheter, PCA with fentanyl or adjusted morphine. Laparoscopic surgeries need less analgesia. Multimodal approach preferred. NSAIDs usually avoided. Paracetamol and oral opioids are alternatives. Thromboprophylaxis recommended. Summary: assess renal function and comorbidities thoroughly. Be cautious with positioning and fluid management. Prepare for possible hemorrhage and use appropriate analgesia. Cystoscopic procedures. Oxford Handbook of Anesthesia. Common procedures: cystoscopy, TURP, bladder neck incision, transurethral bladder tumor resection, ureteroscopy, stone removal, and stent insertion are commonly performed cystoscopically. Patient population and risks. Most patients are older, 60 plus, undergoing surgery for BPH or bladder cancer. Bladder cancer is linked to smoking. Many patients have CAD or COPD. Preoperative tests: FBC, creatinine, and electrolytes should be checked due to potential bleeding or obstructive uropathy from bladder pathology. Flexible cystoscopy diagnostic, typically done under local anesthesia. Biopsies and ureteric catheterization possible. Sedation, e.g., midazolam or propofol, may be needed in some patients. Rigid cystoscopy requires GA due to scope size and bladder distension. Risks include systemic fluid overload from irrigants. Spinal anesthesia is a good alternative, especially for TURP. Spinal anesthesia considerations: sensory levels, S2, S4 urethra, prostate, bladder neck mucosa, T10, L2 bladder distension. Sedation, e.g., 1-2 mg midazolam or low-dose propofol, is often required. Suitable for COPD patients if they can lie flat without coughing. Use 2.5 to 3 ml hyperbaric bupivacaine 0.5% for a T10 block. Avoid head-down tilt unless the block is inadequate. Ambulatory alternatives: chloroprocaine 1%, 40-50 mg, 40 minutes. Hyperbaric prilocaine 2%, 40-60 mg, 90 minutes. Other considerations: chronic chest disease, use sedation to suppress coughing under regional anesthesia. Spinal cord injury, consider GA or spinal to prevent autonomic hyperreflexia. Lithotomy positioning in elderly, take care, especially with joint replacements. Pacemakers, generally safe if diathermy plate is placed caudally. ICDs, must be turned off preoperatively because of diathermy use. Penile erection, managed by deepening anesthesia, ketamine may help. Antibiotic prophylaxis, single dose covering gram-negative bacteria, e.g., gentamicin 3 mg kg. DVT prophylaxis, stockings or pneumatic compression, LMWH for high-risk cases. Postoperative complications: bladder perforation, extraperitoneal, suprapubic pain, intraperitoneal, generalized or shoulder tip pain, peritonism. Intraperitoneal perforation requires urgent surgery and resuscitation. Bacteremia, septic shock suspect with sudden hypotension post-procedure. Treat rapidly with IV fluids and antibiotics, e.g., gentamicin plus cefuroxime, adjusted to sensitivities. Bladder spasm, painful, involuntary bladder contractions. Suspect if irrigation flow is impaired. Treat with IV diazepam, 2.5 to 5 mg, or hyoscine butyl bromide, 20 mg IV IM. Bleeding and fluid overload commonly discussed in TURP-related anesthesia. Laser TURP and transurethral vaporization of the prostate. Minimally invasive techniques, e.g., laser or heat-based ablation, reduce prostate size with less bleeding and fluid absorption compared to conventional TURP. Often preferred for high-risk patients or those on anticoagulation, due to better hemostasis. Some laser vaporization procedures can be performed under local anesthesia in outpatient settings. Brachytherapy for localized prostate carcinoma involves insertion of radioactive pellets into the prostate under ultrasound guidance. Typically performed in the radiotherapy department, not the operating theater. May require multiple procedures in one day. Spinal catheter with top-ups is effective for repeated sessions. For a single session, a spinal with 0.5% bupivacaine plus fentanyl 15 micrograms provides effective anesthesia and safe transfer. Be mindful of risks associated with remote site anesthesia, transurethral resection of bladder tumor, cystoscopic diathermy resection of bladder tumor, duration 10 to 40 minutes, pain level plus to plus, bladder spasm, common position, lithotomy, blood loss 0 to 500 ml. Anesthetic options: general anesthesia GA with LMA, spinal anesthesia plus or minus sedation. Preoperative considerations: epidemiology: slow-growing bladder epithelial tumors, common in elderly, managed by periodic resection rather than radical surgery. Strong link to smoking, assess for CAD and COPD. Investigations: hemoglobin, chronic blood loss is common. Renal function, obstructive uropathy possible. Previous anesthetic records: many patients have had repeated procedures. Perioperative considerations: obturator spasm, caused by diathermy stimulating the obturator nerve adjacent to lateral bladder wall, leads to sudden adduction of the leg, compromising access and increasing perforation risk. Management: reduce diathermy current, use neuromuscular blockers intermittently if necessary, antibiotic prophylaxis, administer appropriate cover, especially if indwelling catheter or positive urine cultures. Postoperative care: pain management: pain can be significant after extensive resections. Use NSAIDs after checking renal function. Oral opioids may be needed for moderate severe pain. Bladder spasm, common. See standard management, e.g., diazepam, hyoscine. Special considerations: spinal anesthesia. Ensure block level is above T10 to cover pain from bladder distension. Open simple prostatectomy and radical prostatectomy. Procedure overview: simple retropubic, Millen procedure, open excision of hypertrophied benign prostate, shelled from its capsule. Radical retropubic prostatectomy, complete excision of malignant prostate plus pelvic lymph nodes. Bladder neck urethral anastomosis. Anesthetic techniques: GA plus or minus adjuncts, e.g., remifentanil infusion. Preoperative considerations: simple prostatectomy, typically for elderly men with BPH, managed similarly to TURP. Elderly patients, multiple comorbids. Investigations and optimization according to comorbids. Radical prostatectomy, reserved for younger, medically fit patients with localized malignancy. Investigations: check renal function. Cross-match blood, arrange for cell salvage if available. Optimize analgesia, consider COX-2 inhibitors, gabapentinoids, and dexamethasone preoperatively. HDU bed, consider postoperative HDU for radical prostatectomy, depending on patient risk and hospital policy. Perioperative considerations: preparation for major blood loss, use large bore IV access, blood warmer, forced air warming blanket. Ensure blood availability, reorder intraoperatively if needed. Incisions: simple, Phanon-steel type radical, lower midline monitoring, arterial line and CVP or CO monitoring may be indicated in patients with cardiovascular disease. Intraoperative risks: air embolism, rare, but possible. Epidural analgesia not recommended per ESRA Prospect guidelines. Remifentanil infusion may be beneficial for intraoperative analgesia and control. Postoperative management: analgesia, simple, LA wound infiltration at closure. Radical, lidocaine infusion recommended. PCA is an alternative. Nephrectomy and partial nephrectomy indication: nephrectomy, tumor, non-functioning kidney, renovascular disease, liver donation. Partial nephrectomy, preferred for organ-confined tumors, 7 cm, surgical approach open, for large tumors, polycystic kidneys, paramedian transverse or loin incision. Laparoscopic robot-assisted, increasingly common. Loin incision, requires lateral kidney position, monitor for BP drop due to venous return or IVC compression, anesthesia plan, ET plus IPPV. Analgesia, thoracic epidural high block, wound infiltration catheter, PCA or opioid infusion. Consider intercostal block for loin incision and rectus sheath catheters for anterior approach. Preoperative considerations: pathology, incision, and approach. HB, renal tumors may cause anemia. BP and renal function, risk of renovascular HTN, CKD. Electrolytes, risk of SIADH, CXR metastasis effusion. Plan for cell salvage if expected blood loss is high. Intraoperative concerns: blood loss, ranges from 300 to 3000 ml. Prepare group and screen X match. Vascular control may require IVC clamping, sudden CO monitoring, arterial line, central line, large bore IVs, fluid warmers, vasopressors, inotropes, metaraminal, ephedrine ready. Partial nephrectomy, risk of more bleeding. May use Manidol 12.5 grams, furosemide 10 mg, heparin 3000 units, ice cooling to reduce ischemic injury, postoperative management, pain control, epidural to T7/8, PCA, NSAIDs if renal function permits. Monitor hourly urine output. Renal function, optimize fluids, HDU admission if pre-op impairment present. Radical cystectomy, procedure, bladder removal plus urinary diversion, e.g., ileal conduit, or orthotopic neobladder. Duration, 3 to 5 hours, longer with reconstruction. Pain, position, lithotomy plus Trendelenburg, head down. Blood loss, 702, 3000 ml, prepare X match 4 units, use cell salvage, discontinue after bowel opening, anesthetic technique, ET plus IPPV monitoring, arterial line plus or minus CVP or esophageal Doppler analgesia, rectus sheath catheters, PCA, or epidural. Used less commonly other, remifentanil infusion for stable anesthesia and mild hypotension, large bore IVs, blood warmer, forced air warming to reduce hypothermia, antibiotic prophylaxis is for bowel surgery. Preoperative considerations: assess cardiac IHD, pulmonary COPD status, renal function, FBC. Ensure thromboprophylaxis is ordered. Plan for HDU admission as per local policy or patient comorbidities. Consider placing patient on an enhanced recovery pathway. Intraoperative considerations: prepare for major blood loss, especially from pelvic venous plexuses, can be insidious way swabs. If using rectus sheath catheters, insert after induction due to surgical access issues. Epidurals may be inserted but used cautiously intraop. Activate after major bleeding is controlled. NGT use is uncommon, check with surgeon if needed. Risk of air embolism, as with all major pelvic surgery. Discontinue cell salvage once bowel is open to avoid contamination. Postoperative management, pain control, rectus sheath catheters up to 5 days. Plus or minus PCA. Visceral pain usually lasts 24-36 hours. Opioids often required. Benefits of rectus sheath technique: supports early mobilization, promotes bowel recovery. Shortens ileus and hospital stay. Use CVP plus hourly UO to guide fluids. Losses are typically high. Third spacing plus ileus. Monitor urine output. Ileal conduit. Drainage is positional and hard to quantify. Neobladder. Urine drains via multiple catheters. Manual hourly calculation needed. Early feeding encouraged. Enhanced recovery. Check abdominal drains. Suspect ureteric leak if urine-like fluid appears. Compare drain fluid versus conduit urine biochemistry. Use NSAIDs cautiously, especially with reconstruction, due to potential for anastomotic leak and renal impact. Extracorporeal shock wave lithotripsy, ESWL, procedure, non-invasive fragmentation of renal stones using pulsed ultrasound. Duration, 20 to 40 minutes. Pain, mild to moderate, blood loss, non-anesthetic technique, adults, sedation, children, general anesthesia with laryngeal mask. Airway LMA overview: originally required water bath suspension, now obsolete. Modern lithotripters focus energy more precisely. Most cases need only minimal sedation or analgesia. Preoperative considerations: check past treatments. Patients may have undergone previous ESWL. Review records for complications or effectiveness. Premedication, paracetamol or NSAIDs often sufficient. Monitor renal function. Perioperative considerations: patient positioning, lateral position, arms above the head. Stone localization, done using ultrasound or image intensifier. Shock wave delivery, focused precisely on stones. Antibiotics, prophylaxis may be necessary, especially with risk of infection or indwelling catheters. Stents, postoperative care: discomfort usually mild. Managed with oral analgesics or NSAIDs. Special considerations: cardiac dysrhythmias, can occur with shock waves, usually self-limiting. If persistent, synchronize with ECG during refractory period. Use glycopyrronium 200 micrograms to increase HR. More frequent shocks. Pacemakers, shock waves can deprogram pacemakers. Always consult pacemaker technician before the procedure. Epidural concerns: shock waves release energy at air-water interfaces. Use 0.9% NaCl not air, for loss of resistance when placing an epidural. Remaining obstetric and cardiac topics. Peripartum cardiomyopathy (PPCM) is a rare form of heart failure that arises late in pregnancy or within 5 months postpartum. It occurs without any prior known heart disease and no other identifiable cause. It can be life-threatening, and early recognition is key for better outcomes. Incidence rates vary widely from 1 in 3,000 to 1 in 10,000 pregnancies. True prevalence is uncertain due to diagnostic challenges and underreporting. Etiology and pathophysiology. The exact cause is unknown, but several mechanisms are suspected. Immune system dysregulation, hormonal imbalances, e.g., prolactin fragments, myocardial inflammation, myocarditis. Genetic predisposition leads to left ventricular systolic dysfunction with decreased ejection fraction. Heart tries to compensate by dilating the 55 to maintain output, eventually failing. Clinical features and diagnosis. Symptoms may resemble normal pregnancy signs: breathlessness, fatigue, edema. Common signs include dyspnea, orthonoia, PND, palpitations, edema, and sometimes hemoptysis. Arrhythmias such as SVT, AF, and VT can occur. High risk of thromboembolism due to mural thrombus. Diagnosis requires exclusion of other causes and specific echocardiographic findings. Diagnostic criteria to diagnose PPCM. All 4 criteria must be met. 1. Heart failure onset in late pregnancy or within 5 months postpartum. 2. No other identifiable cause of heart failure. 3. No previous heart disease before late pregnancy. 4. 55 ejection fraction 45% or fractional shortening 30%. Note, if similar symptoms present earlier in pregnancy, it may be termed pregnancy-associated cardiomyopathy, PACM. Risk factors: maternal age, 30, multiparity, multiple pregnancies, African or Caribbean descent, obesity, hypertensive disorders in pregnancy, use of tocolytics, e.g., Greek letter beta agonists, cocaine use. Differential diagnosis must rule out other causes of sudden cardiac or respiratory symptoms. Pulmonary embolism, sepsis, amniotic fluid embolism, preeclampsia, arrhythmias, anemia, myocardial infarction, other cardiomyopathies. Investigations: ECG, nonspecific but often abnormal, e.g., LBBB, echo. Key for diagnosis: shows dilated 55, reduced EF, cardiac MRI, BNP, viral serology, coronary angiography, useful for excluding other causes. Prognosis: mortality ranges 15 to 50%, about 30 to 50% recover normal 55 function. Poor prognosis associated with low EF at presentation, high NIHA class, and complications like arrhythmias or thromboembolism. Management: multidisciplinary care is critical. Obstetrician, cardiologist, anesthetist, intensivist should be involved. Delivery planning and neonatal team involvement are essential. Pharmacological treatment, postpartum